Hello everyone, this is Dr. Madhusudhan Rao and the program I teach medical students. Today in my lesson I am going to talk about mitral stenosis. When do you call mitral valve is stenosed? On physiological grounds, when there is a gradient exists across the valve, it is called stenosis. Normally there is no pressure gradient between the left atrium and the left ventricle. Okay? Whatever the blood is received by the left atrium through the pulmonary veins, it is emptied into the left ventricle during ventricular diastole because there is no pressure gradient between those two chambers across the mitral valve. Only small quantity of the blood remains in the left atrium, which is ejected into the left ventricle in the end diastolic phase of the left ventricle due to atrial contraction. Okay, this is what happens in health. Normal size of the mitral valve is 4 to 6 square centimeters. It is a bicuspid valve. When narrowing occurs to the size of 2 square centimeters, there is rising pressure in the left atrium, and left atrium has to generate a pressure of nearly 25 mmHg in order to pump the blood into the left ventricle against resistance. Normal pressure in the left ventricle is around 20 mmHg. Okay. When there is narrowing of the mitral valve, left atrium has to generate a pressure of nearly 25 mmHg in order to eject the blood into the left ventricle. So, this situation occurs in mitral stenosis. That means mitral stenosis is the condition where the narrowing of the mitral valve occurs, generating a gradient between the left atrium and the left ventricle due to obstruction to the flow of blood. Then, rheumatic fever is the most common cause of mitral stenosis. Okay, but it takes longer time to become symptomatic following rheumatic fever. But when there is recurrent rheumatic endocarditis or recurrent rheumatic valvulitis, symptoms occur earlier than earlier than that is described in the Western literature. Okay, they say to become rheumatic mitral stenosis symptomatic, it will take third to fourth decade of life. But we see in the Indian population symptomatic rheumatic stenosis occurring in around second decade of life itself. Okay, that is around 8 to 10 years following the onset of rheumatic fever. Because streptococcal sore throat is very common in our community, and the recurrence of the rheumatic fever is very frequent. That results in the recurrent rheumatic mitral valvulitis, ultimately resulting in symptomatic mitral stenosis. Earlier than that, we see in the Western literature. Girls are commonly affected than the boys. Okay. Well, there are other rare causes of mitral stenosis, which include congenital mitral stenosis, calcified mitral valve ring, bacterial endocarditis, endocardial fibroelastosis, systemic lupus erythematosus. Okay, there are certain, these are certain of the rare conditions of mitral stenosis. Look at this picture. This shows, this is the normal heart with left atrium and the left ventricle. Blood is freely flowing from the left atrium into the left ventricle. Okay, it is narrowing of the mitral wall. Results obstruction to the flow of blood from the left atrium to the left ventricle, and you see the dilatation of the left atrial chamber and compared to the size of the left atrium in normal heart. This picture again shows narrowing of the orifice of the mitral wall with enlargement of the left atrium. Well, we'll see certain of the images related to the X-ray chest in patients with mitral stenosis. The demarcation here is the atrial shadow in the atrium in the cardiac shell aorta, demarcating the enlarged left atrium. This is white lines you see. This is the enlarged left atrium. This shows, X-ray shows enlarged left atrium, displacing the left atrial appendage outward. So there is displacement of the left atrial appendage, resulting in the straightening of the left border of the heart. You can see on the right side a double density overlapping of the left atrium. This is the left atrium and right atrium. So this is the right atrial margin, this is the left atrial margin. Both are overlapped there. You can also see left main bronchus is elevated by the enlarged left atrium, pushing it upwards. This is what happens. If you take the barium swallow and take a shot into the LAO position, you see the pressure of the left atrium on the esophagus showing the sickle shape. This is the sickling sign of the esophagus in barium swallow due to enlargement of the left atrium. Well, we consider these images in the diagnosis of the mitral stenosis. Well, let us come to the pathophysiology. As I told you, normal mitral valve is 4 to 6 square centimeters, a bicuspid wall. Blood flow from the left atrium to left ventricle during ventricular diastole as the pressure in the both chambers is equal. Okay, as I told you, there is no gradient across the mitral wall normally. The blood that is received from the pulmonary veins into the left atrium flows into the left ventricle during the ventricular diastole. Only little amount of the blood that remains in the left atrium is pushed into the left ventricle at end diastole of the left ventricle due to atrial contraction. That's what normally happens. But in the situation where there is narrowing of the mitral wall due to its fibrosis, that results in the impedance to the flow of blood from the left atrium to the left ventricle. Okay. Pathologically, there is fibrosis of the mitral ring addition of the commissures, contractures of the leaflets, and cardiac tendon and the papillary muscles as a result of the recurrent rheumatic mitral valvulitis. Okay, verrucae that form during each episode of mitral valvulitis, the healing takes place in formation of fibrous tissue that results in the contractures and narrowing of the mitral valve orifice. When the narrowing occurs to the size of nearly 2 square centimeters, left atrium has to generate a pressure of 25 mmHg in order to empty the blood into the left ventricle. Okay, against the resistance, because left ventricular pressure is normally around 20 mmHg. These changes occur over time and about 10 years following the rheumatic fever. But once the symptoms occurs, progression occurs very rapidly. Okay, so there will be rising left atrial pressure and left atrial enlargement or hypertrophy, and the pressure is transmitted backwards into the pulmonary veins. Pulmonary venous hypertension, pulmonary congestion, followed by pulmonary arterial hypertension, and right heart failure. Okay, and when there is enlargement of the left atrium, there is a risk of developing atrial fibrillation, atrial thrombosis, and leading on to embolic manifestations. So, once symptoms set in, there is early onset of left heart failure, that is followed by the right heart failure and congestive heart failure. Okay. You look into this picture. This is the mitral wall that is fibrosed, resulting in extreme narrowing. So, how does this patient with mitral stenosis presents to you? In mild cases, the patient is usually asymptomatic, heart is normal in size. Okay, when you auscultate, peripheral signs are normal. Okay, pulse is normal, volume is normal, blood pressure is normal. Okay, and there is no JVP. When you auscultate the heart, there is first sound is loud because of the tension generated into the mitral valve leaflet during the atrial contraction, and followed by sudden closure of the leaflets results in the loud first sound. There is mitral opening snap, that is sudden clicky sound in following the second heart sound, that is opening of the mitral valves when there is excessive gradient across the valve leaflets, sets in the turbulence in the leaflets, resulting in sudden sharp sound following the second heart sound that occurs in the early diastole. Well, closer the opening snap to the second heart sound, it is said severe is the mitral stenosis. Then you'll see the low pitch pre-systolic murmur at the apex, right? That is because of the turbulence generated in the narrowed valve leaflets during atrial contraction. that occurs in the end diastolic phase of the left ventricle. So these are the features you see in the mild mitral stenosis. Apical impulse is normal, first sound is loud, there is opening snap followed by pre-systolic murmur, which is low pitched, best heard with the bell of the stethoscope with the patient in left lateral position. In the same position, you can appreciate diastolic thrill. Okay. In moderately severe or severe stenosis, the patient starts developing the symptoms of left heart failure. Initially, first symptom being the paroxysmal nocturnal dyspnea. Okay, it occurs in the paroxysm. Symptoms set in while the patient is in sleep. Okay, suddenly wakes up with the severe breathlessness, air hunger, followed by cough and hemoptysis. Why should it occur in paroxysms only at night? It is during the sleep that compensatory mechanisms will be dampened and there is severe pulmonary congestion resulting in the sudden episode of breathlessness, cough, sometimes hemoptysis. This is secondary to the pulmonary edema that occurs due to increased pulmonary venous congestion. Then there will be orthopnea, that is breathlessness while patient is lying down. Then there is exertional dyspnea, exercise intolerance, loss of weight, loss of appetite. Okay. Then there will be sometimes abdominal pain, secondary to the congestion, peripheral congestion, hepatic congestion, enlargement of the liver, right? There could be abdominal distension, edema feet. These are all the features of right heart failure. When you examine, apical impulse is tapping in nature. There is diastolic thrill at the apex, loud first sound with mid-diastolic murmur with pre-systolic accentuation. This is classical. Mid-diastolic murmur with pre-systolic accentuation is the classical sign of organic mitral stenosis. Okay, there could be functional mitral stenosis where there is flow of blood across the mitral valve is very high volume of blood is passing across the normal mitral valve in situations of large left to right shunts like PDA, large ventricular septal defect, when there is trafficking of the lot high blood volume which is ejected from left to right and there is increased flow across the mitral valve of normal size from the left atrium into the left ventricle that can generate mid-diastolic murmur. Okay, presence of mid-diastolic murmur in large left to right shunts, okay, is diagnostic of pulmonary systemic flow ratios of more than 2:1 in left to right shunts. Okay, in that occasion you will appreciate the mid-diastolic murmur, but there is no pre-systolic accentuation. Presence of pre-systolic accentuation is diagnostic of organic mitral stenosis. Right? It disappears with the onset of the atrial fibrillation because there is no effective left atrial contraction in atrial fibrillation and there is a disappearance of the pre-systolic accentuation part of the mid-diastolic murmur that usually seen in the mitral stenosis and disappearance of the opening snap with the sclerosed, tight, mitral valve leaflets, that are rigid and not pliable. Loud first sound with mid-diastolic murmur and pre-systolic accentuation. Loud pulmonary component of the second heart sound. Okay, that is because of the presence of pulmonary arterial hypertension because of the backward pressure. Then there could be early diastolic murmur in pulmonic area. What is the name of that murmur called? Graham-Steele murmur. There is holocystic murmur at the tricuspid area with rise in JVP. When there is a mounting up of pulmonary arterial pressure with pulmonary valve regurgitation, and there could be backward pressure mounting up in the right ventricle, and there is dilatation of the right ventricle and incompetence of the tricuspid wall that results in the tricuspid incompetence. Then you appreciate the pansystolic movement in the tricuspid area and raise in JVP. Presence of abdominally, ascites, and edema fail are the other signs of right heart failure. Okay. So these are the features of mitral stenosis with congestive heart failure. In long-standing cases of mitral stenosis, patient may complain of difficulty in swallowing, dysphagia, that is because of the pressure of the left atrium onto the esophagus, resulting in dysphagia or difficulty in swallowing. And he may also develop hoarseness of voice because of the pressure on recurrent laryngeal nerve. Okay, these are the other features of the clinical presentation of the moderately severe long-standing mitral stenosis. Okay, is it clear? Let us see some of the pictures. This is a section of the heart showing the mitral valve narrowing here and enlarged left atrial chamber. Okay, you see the echocardiography taken with the left parasternal long axis view, showing the left atrium, left ventricle, and the narrowing of the mitral valve. It is the anterior leaflet, it is the posterior leaflet of the bicuspid valve, that is the mitral valve. The orifice being narrowed, requiring left atrium to contract against resistance, thereby generating a gradient across the valve. Well, this we have seen the X-ray earlier. This is the enlarged left atrium, shadow in shadow of the left atrium and the right atrium here. And the pushing leftwards of the left atrial appendage, making the left border of the cardiac still straightened. Then, what is the normal workup you do on the patient with mitral stenosis? X-ray chest, which has shown already, left atrial enlargement, prominent pulmonary trunk, enlarged right ventricle and right atrium in late stages of mitral stenosis with congestive heart failure. Sometimes you see the calcified mitral valve. ECG shows prominent bifid P waves, that is P mitral. Signs of right ventricular hypertrophy with right axis deviation. Echocardiography shows left atrial enlargement, narrowed mitral valve orifice, okay, and you can observe the gradient across the mitral valve. Cardiac catheterization is usually not required for the diagnosis of mitral valve, mitral stenosis, but if done, there is diastolic gradient across the mitral valve. Okay. Usually there is no gradient. If there is a gradient means there is stenosis in physiological terms. And there is a degree of pulmonary arterial pressure mounting up. Okay. These are the things you can see in the cardiac catheterization. And these measurements are very much required when you contemplate surgery with valve replacement. Okay. Because rising pulmonary arterial hypertension is a risk factor for valve replacement surgery. Well, you can see the premitral here. This is the premitral. It starts here, bifid, wide and bifid, with a dip at the end, less than 1 mm. This is the premitral. This shows delayed and prolonged left atrial depolarization. This is the X-ray showing the margins of the enlarged left atrium. You see, enlarged left atrium. This is normal left atrium. When it is enlarged, you see the borders. Yeah. This is the premitral, broad and notched. Again, you can see the X-ray chart showing left atrial appendage, main pulmonary artery segment is prominent, aortic knuckle, and prominent horizontal fissure because of pulmonary edema. And this picture shows the areas you are concentrated to auscultate. These are the auscultative findings in mitral valve disease. These are the findings you see in the mitral stenosis. This is loud first sound. P2 is loud, you see, as loud as the A2, and there is opening snap following the second heart sound. That is followed by the mid-diastolic murmur, which gets accentuated in the end diastole. Pre-systolic accentuation. So, if left untreated, what are the complications you encounter? The patient may go into congestive heart failure. Okay. Atrial fibrillation is a serious complication which may lead to atrial thrombosis and other thromboembolic complications. Infective endocarditis, left atrial thrombus leading on to thromboembolic phenomena. Okay, these are the things that can happen if the patient is left untreated. So treatment is mandatory, and with good counseling and follow-up, patient to be put into medical management followed by surgical. What is the medical management? But by and large, the medical management is not going to give complete relief for an obstructive lesion like mitral stenosis. So, but palliative improvement, temporary relief for the symptoms can be achieved by diuretics that is, which can help reduce the pulmonary congestion and pulmonary edema in terms of paroxysmal nocturnal dyspnea or orthopnea, etc. And we can give the beta blockers in order to get relief of tachycardia. Then associated symptoms of palpitation can have the temporary relief with beta blockers. And treatment of arrhythmias and prophylaxis for rheumatic fever and infective endocarditis. Okay, that is primary prophylaxis for rheumatic fever is treatment of the streptococcal throat infections effectively every time child presents with throat infection with streptococci. Then prophylaxis for infective endocarditis is secondary prophylaxis, that is benzathine penicillin every 3 weeks, around 12 lakhs units for about 20 years following the initial attack of rheumatic fever. Then anticoagulant therapy is indicated in patients with mitral stenosis, okay, with strict monitoring in order to avoid the thromboembolic complications. Then every patient with symptomatic mitral stenosis should be counseled to undergo surgery. Surgical correction is the treatment of choice for symptomatic mitral stenosis. Once the symptoms set in, the longevity is not more than 3 years. With the advanced surgical procedures available with the availability of the valvular replacement, valve replacement therapy, that is a mitral valve replacement with processes, MVR, is the treatment of choice nowadays with good improvement and longevity of life without mortality and morbidity. Right? Yes, but following surgery and the valve replacement, anticoagulant therapy should be continued lifelong with strict monitoring. So valve replacement therapy is going to improve the well-being of the patient with good effort and effort tolerance. Okay, and they will improve symptomatically as well as with regard to exercise tolerance. Because we have seen the patients with a congenital tight mitral stenosis with pulmonary hypertension who underwent valve replacement surgery in our centers, and they are doing good even today. They are on continuous anticoagulant therapy with monitoring. Well, this is the brief talk on the mitral stenosis. Thank you for patient listening, and we'll meet again next class. Until that time, bye bye and see you. Before that, I'll make a point about prognosis. Well, though the rheumatic fever is the commonest cause of mitral stenosis, progression occurs very slowly if there is no recurrence of rheumatic endocarditis, but becomes symptomatic around 10 years after the rheumatic fever. Once symptoms occur, there is rapid progression and survival time is only around 3 years without surgical intervention. So, as I told you, medical management is of limited value because it is an obstructive lesion at the mitral valve and limited cardiac output. Whatever the medical management you are giving, it cannot overcome the obstruction. Okay, And so the medical management helps only to relieve the pulmonary congestion and temporary improvement. But surgical intervention is mandatory in order to improve the lifespan. Valve replacement followed by anticoagulant therapy with monitoring improves the quality of life. This is the treatment of choice nowadays with the availability of the prosthetic replacement surgery. Well, thank you very much once again for patient listening. We'll meet you again in the next class. Until that time, bye bye.